Tremblay. For those who don't, Dr. Tremblay is a pulmonologist, does a lot of work with lung cancer, and we have the Dean Stilchuk with us who works with him in this particular program that I'm talking about. So we wanted to introduce you to this Alberta Thoracic Oncology program. It's been going for, what, a couple of years?
3 now? Is it 30?
You know, anyway, but it's been really limited to the cardiothoracic group. And the idea behind it is that to really expedite the treatment of lung cancer, because you might see some slides. It's amazing from suspicion to when actually anything happens, you know, with it, how long a period of time it is. So it's been tried to, we'll set up the program, with Dr. Tremblay set up the program, so that we can expedite the management of it. It's pretty straightforward, but we want now to expand it to just beyond the cardiothoracic group to basically anybody else who does you know, radiology and reads images, except we're limited to CT findings, okay? So it's not lung findings at this point in time that we were suspicious of so far. It's going to be on CT, okay? So I'll just turn it over to Dr. Tremblay.
Great. Well, thanks, Paul, for having us. I just have a few slides to kind of give you a sense of what it is we're trying to do. This is a chart review we did initially. Oops, that wasn't good. Sorry. We did initially, and you know, from the time someone gets a CT to the time they get to surgery, it's a ridiculously long wait time. You know, that's median 130 days, and then you're up to half a year to get to our 75th percentile. So it's really way too long. And there's delays all through, and you know, there's smaller delays in between, but there's just all kinds of delays. So when we start looking at it, we say, okay, well, we can't just say we need more surgeons and more operating rooms. Yes, maybe we do, but we need to look at every little piece of the puzzle. And the first, you know, starting at the CT, and there are actually some delays before as well. Patient delays, you know, when you don't seek medical attention, maybe between the X-ray and the CT. But from the time of the CT to actually a consult being received by the surgeon, there's actually, you know, between 30 days median, you know, and then up, you know, 2.5 months, you know, to actually just get the patient to the right person. Like, so there's a lot of benefit of work that can be done there. You know, what we're looking for is 60 days. You know, so we're pretty far from that 182 days. So we're trying to get that better. So this is actually data for the past couple of years in our clinic. So this is the time from a CT scan that shows a lesion suspicious for lung cancer, and the time that not that we see the patient, that we actually just get the facts from whoever's referring it to us. And you can see our 75th percentile just is above 20 days, so maybe a little better than what we had before. You know, we've done a lot of work telling people that we're here and that we're seeing patients quickly and all that, but it still takes, you know, almost 3 weeks from the time a CT scan is done to a GP, or, for example, sending us a referral. So there's lots of opportunity to improve that, and you guys actually know right away on the same day or the next day at the latest, I think, that there's something on the CT. So why are we spending 3 weeks for something that you guys already know needs to happen? Is they need to see a group of people that can work up their lung cancer. So we started about a year ago now, over a year ago, with the 5 chest guys and gals. And basically what we did is we've asked them, based on some criteria that are going to be on these cards we're going to give you. And we even have coffee mugs that you guys can have later. If you guys like them, you can order some. We set up some fairly straightforward criteria. We don't want every small ditzel, right? I mean, we'll go nuts if we get all of those. We want something that really looks like lung cancer. So nodules more than 8 millimeters, growing nodules, persistent ground glass opacity. So we don't want pneumonias. We want, you know, these GGOs that are persistent or growing, or mediastinal stuff that looks like cancer. So again, we don't want all the sarcoid-looking things. We want things. So this is, you know, not your typical sarcoid. So those are the things we're looking for. This report came out a few months ago from the Health Quality Council. Very interesting read if you haven't seen that. It's on their website. It was a young patient who had ended up dying of testicular cancer, but massive PE, and it's quite remarkable to see his path through the system. you know, radiologist saying you needs an urgent CT, but then no one really gets the report or doesn't get you know, all these kind of things that we actually see every day, but led to a tragic outcome. And one of their recommendation was that, you know, the ASR and the college and AHS should look at policies and procedures that would allow radiologists to expedite the care of patients who they find have a time-sensitive health condition. And there's kind of two things they say. You can actually directly order the next test. So for example, if you saw a chest x-ray with a big mass, maybe you guys can do the CT right away. That's not what we're tackling, but maybe we should at one point. We're kind of on a number 2 here, and of course we started this a year before this report. Directly referring a patient who has a time-sensitive health condition to a clinical service when it is obvious the patient requires that expertise to move to the next level of care. So this is actually what we've been doing. We kind of predated this by a year, and actually we told them we were doing this, and they said that's great because we didn't think anyone was looking at such an initiative. And I guess the point would be that our project might be one of the first ones you see, but I suspect you guys are going to see a lot more of these projects for other conditions other than lung cancer, where you're asked to trigger the next step. And I guess in mammography, it's kind of standard now that you guys often do the next step. So it's kind of that, along those lines. So what happens if you guys see a CT, and we're only talking about CTs now, that is suspicious for lung cancer, and we have those criteria, but essentially, you know, when you think something might be lung cancer, there's a way to trigger the system, and we'll show you that in a minute. And then we get a list, Nadine gets a list every morning of those scans, and then we can look at the scan, and, you know, assuming it meets the criteria, we send a note to the ordering physician that essentially says, you know, do you know about this report? We're here to help. Do you want us to see the patient? And we decided we're actually going to give him an appointment date right then and there to say, look, we can see him next Monday. Do you want us to see the patient? And they can say yes or no. They can say, no, don't. I know about it. I'll deal with it. Or they can say, please go ahead and see the patient. So that's kind of the way the system works. So we're trying to get rid of that 3 weeks period. So far, we've got, I think, some promising results. We're changing our processes, I think, to try to improve that. And we've got about 70 cases in the first year, again, with a small group of radiologists. And you can see that our median time when they're through the system, it takes us 19 days to see the patient in the office versus 26 days. So only a week saved here. We were hoping for a little bit more. And I think what's happening now is we send a note to the family doc, and it actually takes us about a week to get that reply back. So we're losing a lot of time there. So I think what we've decided we're going to do is we're actually going to book the patient in at the same time, so that we're not losing another week there. So we should be able, from our side, to decrease that further. But in any case, you're looking at, you know, about a 25% drop in our time to the first appointment. So again, if you reduce the whole thing by 25%, it starts to be a few months with all the different steps.
Can I just ask a question at this point?
Yeah.
So we're talking about 69 cases over that period of time.
Yeah.
So would it not be possible or effective for direct verbal communication rather than?
It could be. So this is 5 radiologists. If we went to, because the next step I'll tell you later is we want to go foothills wide now. And then we want to go citywide, then we want to go province-wide.
Right, right. I mean, so the numbers are going to be
much bigger
more.
than that.
No, I understand, but.
And right now we're seeing per year about, what, 600 patients? So, you know, you can imagine that at one point all 600 would have come through this process as it expands. So it would become challenging, I think, to do it verbally, both for the radiologist who's, you know, sitting there waiting for someone to call back, and for us to actually be available to, you know, for unscheduled calls, if you want. So
we want to make it as simple as possible. You'll see we'll go over
You'll see
what
it's pretty
radiologist
simple,
needs
yeah.
to do.
Right.
It's just a 2-step
Yeah.
sort of process, so it doesn't. You don't have to phone, wait, leave a message, all that sort of thing. So
Right.
I think
No, I'm
it's
just
simpler.
looking in terms of, you know, like the amount of time that you've shaved off. Like you shaved off 7
Yeah.
days. I mean, I would think you would shave off substantially
yeah,
more.
we want one more. But the delay is not at this point radiology to us.
Okay.
It's from us to the ordering
I
physician,
understand.
because we didn't want. So are you saying communication with the ordering?
Yeah.
So we did think about that.
Yeah.
It is tough to get a hold of these people, especially the
I
family docs,
Understood.
because they're not on pagers.
Yeah.
You know, you get their front desk.
Yeah.
And in general, Nadine, you can speak for this. The reply's been improving, I think, as this is rolling out.
Yeah, I've noticed since Christmas, it's more anecdotal, but I'll send out a letter, and by the next day, we'll have a whole fax copy of the patient's file to us saying, yes, please step in.
Oh, really?
So it's, I'm actually seeing that it's sort of rolling a little faster.
Okay.
I think the challenge with the phone calls is that we tried that, and we ended up doing a lot of callbacks and not really getting anywhere. You know, and I'm sure you appreciate that, and it's sort of a lot of energy to put into that, you know, because we have other